Time to rock and roll and kick the new year off. And everyone's flooding in. Yay. Thank you for starting 2023 with us 5 days in. And we are so excited to start the new year off with Chris Borms, president of Precorporation, tonight. He had a fantastic webinar here with us last June. And we received tremendous demand to bring him back with additional content, especially around the implants. So we hope you are as excited as we think you are. I'm Jessica Respondek. I'm here with NDX. I am your education manager. I'm going to kick off tonight. I'm going to review your housekeeping tips and tricks. If you know our drill, it takes about 2.5 minutes to run through everything. And then we will introduce Chris and start the show. So welcome to the Implant Supported and Retained Overdenture Bars webinar being presented by Chris Borms, MI, COI, and we will begin shortly. For housekeeping, general reminder, tonight's content is being recorded for future educational purposes. Question and answers button located in the middle of the bottom of your screen to the right. Please use the Q&A button for any comments or questions as the presentation moves along, and we'll be more than happy to address all entries at the end of the presentation. Please note the Q&A section allows an attendee to ask questions anonymously. Should you not wish to have your name shared with the audience, please be sure to check that option. Chat function, it's located in the middle of the bottom of your screen to the left. Feel free to use the chat box for any technical questions or concerns, or merely say hello and engage with other participants. The raise your hand, it's located in the middle of the bottom of your screen. Feel free to raise your hand so you may ask your questions live at the end of the presentation. Now I'm about to dive into CE certificates, so bear with me, it is a long one. CE certificates will be issued post-webinar to the email address used to register for today's session. Please feel free to email ndxeducation@nationaldentex.com if you don't receive your certificate after 5 business days. And please include your name, course date, and course title to help us search for your record. Please note, to earn a certificate, a participant must be logged in with the email used to register for this session and be engaged in attendance for the length of the course. Failure to not meet these guidelines will result in the lack of CE credits. And tonight, if you logged in using somebody else's registration link, we encourage you to log off, register, and log back in with your unique link. Otherwise, we will not know that you attended the event, and the system won't be able to issue you a certificate. The registration links may be found at nationaldentex.com/education. And if you decided to phone in this evening without logging into your desktop, please email ndxeducation@nationaldentex.com and include your name and phone number, as the system does not recognize phone numbers in the certificate issuance verification process. Post-webinar survey. A survey is going to pop up at the close of the webinar on your web browser, and the link will be sent in a follow-up email thanking you for attending. We ask for your completion with valuable feedback and include any suggestions on what you would like to learn about in the future. And one last item before we begin, please know we recognize the abundance of learning options available, and we truly appreciate you for affording NDX Education your time, attention, and participation. And with that, it is my great pleasure to introduce Chris Borms, MI, COI, President of Precorporation. Chris graduated with an accounting degree from Gonzaga University in Spokane, Washington, and then attended the Dental Laboratory Technology program at City College of San Francisco. Over the years, Chris has completed the Tyconium and the Bago partial denture programs, my apologies, and received his COI Mastership in Dental Technology. Mr. Borms authored the Precorporation Technical Manual, invented 6 attachments, and he is a candidate for CDT in complete dentures. Recognized as an attachment and implantology expert, Chris has lectured nationally and internationally, and we have the honor to have him speaking with us tonight. And with that, I get to say, take it away, Chris.
I'm glad that part's over. That part always kills me. It's great to be here tonight, starting off the year with everyone. And with that, we'll jump in because we got a lot of content to cover and we'll get rolling. Tonight's course obviously is on bar overdentures. This is a follow-up per se to what we talked about previously, which was treatment planning the edentulous arch. And as we start off, let's see here. There we go. A couple quick disclosures. Number one, I work for the company with the blue logo. Been there 25 years as of November. Love what I do at the Blast. Second, I'm on the board of the National Association of Dental Laboratories. And final, I'm also on the board of the American Denturist School, which is something I strongly believe in. Those are my disclosures, but once again, this is not a commercial course. So moving forward. Last time we talked about the edentulous patients you're seeing at your practice. And when they present to you, what treatment option are you going to choose? And we talked about, the traditional conventional denture. We talked about the standard treatment modality, 2 implants and a stud or a locator or an O-ring. We talked about bars. We talked about fixed cases. And tonight we're going to go back and we're going to talk specifically about bars. And when we take a look at that, lots of treatment options. But this is the basic catch-up criteria. We want to know, this is the information your laboratory wants to know when you're discussing the best treatment for the patient. They want to see opposing casts. That's at the bare minimum. From that, we can tell the ridge, we can tell how much space we have, both vertical and buccolingual. And obviously we know what's opposing and what the bite forces are. We want to know the bone quality information. Type 1, type 2, type 3, type 4. Just basically, can we cantilever off it? Can we load it? Or do we have to protect it? Are we in type 3 bone in the maxilla and we need to protect that weaker area by splinting or connecting that weak implant to a stronger implant? I'm here in California. We're getting those big storms right now. All of a sudden, out of the blue, the sun just came out. I had to close the blinds, which is actually really nice. Where I'm looking right now in the backyard, I built my kids a fort a couple of years ago. Well, more than that, probably a decade ago. And they walked off the structure they wanted. It was a shape that nobody knows what it is. But, I took my post hole digger, I got down and started digging. First 3 posts I get in there with Quickcrete. Beautiful. 4th one is right in sand. What's the first thing I did once I got that post in there? I connected it to 2 of the stronger posts to help support it. Same idea with bone quality when we're talking about our implant restorations. We want to know the patient's general health and budget. Are they type 2 diabetic? Do they smoke? Do they chew tobacco? We'd love to get digital pictures or videos. This is something an assistant can do with a smartphone. You can have the patient go through all the phonetic sounds, the F, S, Mississippi, 54, 55, different things like that. You can transmit it via tons of online services that are HIPAA compliant, Dropbox being one. Ideally, I would love to know the patient age and also their dexterity and hygiene. And the reason I say that is a lot of the times I'm asked when we're treatment planning, hey, what about a telescopic restoration? And I'll say, fantastic. It's wonderful. It really gives the best of both worlds. You have something that, has a flange, restore lip contours. You can remove it. The patient, it's easy to clean, but it feels fixed. It's not moving. But I want to know the patient's age, because if they're 75, 10 years from now, are they going to have the dexterity to remove it every day? Because if they don't have the dexterity, it's going to swedge down every day and get tighter and tighter, become truly fixed. So I would love to know the dexterity and hygiene. Can they clean our restoration? And finally, diameter, length, position of implants. This goes back to, can we cantilever off it? What's strong? What's weak? What can we load? And, do they brux, grind, chew, stuff like that? And of course, I made this green for a reason. What are the patient's desires and expectations? Because one of the things as clinicians you're fighting is the patient's going online, spending 10 minutes Googling different treatment options, and they come in and all of a sudden they know better than you do. So what are their desires? What are their expectations for the case? And really, what can we deliver? Because our goal is to provide, obviously, the best possible restoration, restore as much function as possible while maintaining aesthetics and something that's cleansable. Simple as that. So when we talk about restoring function, 10% of functional capacity, which is the bottom box, that's our conventional lower denture. We can get to 60%, something that's tissue retained, tissue supported, whether it's a bar or stud, or we can get to 90% of functional capacity with something that is rigid or non-moving. And this can be either fixed or removable. But keeping in mind the difference between implants and natural teeth, as we all know, with implants, we don't have proprioception. There's no periodontal ligament. There's not those built-in shock absorbers. And we have to support this restoration differently than if we would with natural teeth. Now, a simple study I've seen recently, and we talked about this a couple months ago, was when it comes to proprioception. And I used to say there was no proprioception with implants. Well, there is some, but it's called bone deformation. That's 500 times the normal bite force before the patient's nerve receptors get the message, ow, this hurts, or I'm going to break something. With your natural dentition, it's a protective mechanism. With implants, we have bone deformation. So we want to protect our implant restorations in a different way. So we'll just talk real quick about some of the advantages of bars. And the first couple are going to be the advantages of bars as opposed to a stud case. You know, stability. Number one reason we're providing a bar is for stability. Provides retention. You know, we're splinting our abutments. Once again, going back to the analogy of building my weak fort. You have an implant in type 3 bone. You put a stud in there, it's going to fail. You tie it together with a bar, you're going to protect that implant. That's abutment splinting. With bars, we also have the benefit, there's a lot of restorative flexibility. They can be either tissue or abutment supported, sometimes a combination of both. It's easy to accommodate a divergent abutment, multi-units, different things like that when we talk about draw. And these last three I put in yellow because one of the big trends we're seeing is a move from patients who were provided with an all-on X 25 years ago. And for multiple reasons, most of the time it's hygiene. They're having a hard time cleansing it. They're moving to something removable. Now, for 25 years, they've had teeth that don't move. So they don't want that tissue supported prosthesis. If they've had something fixed for that long, they have the placement and the AP spread to provide something that's rigid or non-moving. So some of the benefits of moving a patient from that fixed to removable, both being rigid and non-moving, obviously are the aesthetics. You can restore lip contours, make somebody look younger. It's easier hygiene for the patient. They can remove the prosthesis and clean it much easier than trying to come from the lingual multiple times a day with super floss and clean it. And then independent servicing. This is huge. In your practice, if a patient comes in with a fixed case and says, you know, Dr. Jessica, something feels loose here. You're basically going in, you're opening up all the access channels to that fixed case. You're unscrewing all the screws, hoping it's just a screw that might be broken, getting down to your multi-units, hoping it's not something broken there, hoping it's not a cracked implant, but you have to do it all to take a look. Whereas if a patient comes in, and let's say they have a bar case with 4 locators on it, and says something feels loose. Great. Pop out the insert, pop in a new one for the area they say feels loose, seat it, patient's out the door. You can independently service. It's a huge time saver for the patient and for you in your practice. Now, some of the disadvantages, you know, you have a huge ponic area a patient needs to clean under. Less of a disadvantage than as a fixed case, but if the patient's coming from something that was a 2-implant overdenture, it is a required, increased hygiene. You know, long spans, we want to limit the amount of ponics we have on a bar span. We don't want to torque the abutments. Obviously, a bar requires more space than studs. We're not going to talk too much about engaging undercuts, but ideally, if we had a conventional denture and the patient has huge undercuts, as a technician, I'm super excited because I can engage those for retention and stability. But when I'm seating those on a bar with attachments, there's a path of insertion. And if I have to engage the undercuts and then roll the prosthesis back, I'm going to see my clips on the bar or whatever the retentive elements are bend, fold, and break. And of course, there's an increased cost for a bar. So pros and cons all around. Reduce tongue space. So one of the questions I ask a lot and get asked a lot is, I don't do a lot of bars in my practice. I ask, why not? Man, if you get somebody to have a couple cocktails, they'll tell you, I'm kind of intimidated by doing a bar. So when we talk about our game plan for today, number one, ideally, let's identify the patients who can benefit from a bar. So when these patients present to your practice, we have a game plan. We can reach out to our technician. And if the patient does not have any abutments, whether they're natural teeth or implants, the oral surgeon, and we can put together a game plan. We'll talk about different bar design options. We'll briefly talk about workflow. There's no way we can go through this in an hour, but we'll talk briefly about a couple parts of workflow, and then we'll talk about servicing requirements. So that's going to be the game plan for today. And the goal is going to be at the end of the hour, hopefully you're more comfortable, working with your laboratory partners at NDX to provide these restorations to your patients who need a bar. So it's kind of the game plan for today. So one of the things I like to talk about for a minute is how we can help our patients when it comes to visualizing these different things we're presenting to them, whether it be conventional denture or the all-on-X. And we're showing them models so they can touch and feel, they can see how they work. And this is something you can work with your laboratory partners on at NDX, where you can have a study model showing the Ferrari, the screw retained all-on-X, and you can talk to them about the pros and cons. It's rigid, it's non-moving, it's going to feel fixed like natural teeth. But, there's a lot of requirements for hygiene. And really one of the drawbacks about these fixed cases is you can replace what's lost from the tooth point of view. What you cannot replace is what's lost from the bone and supportive tissue point of view. We lose bone twice as fast horizontally as vertically, and you'll see as we go through, some patients have the vertical lines and they look much older. Now they have these straight, white, beautiful teeth, but they look 10 years older because they don't have the lip contours. They're not flushed out. So we can talk about the pros and cons of these different treatments. The Porsche, this is what we're going to talk about today. This is a fully abutment supported, non-moving restoration. When I'm asked what would I provide my mom, this is what I would provide her. There's the Cadillac, which is going to be a tissue supported bar. And if you take a look at the residual ridge on this, you'll see why we chose a bar for this case as opposed to a stud, simply because with that flat ridge, prosthesis stability is going to be a huge challenge. Bars provide more stability, hence this patient was delivered a bar. The two on the floor, the Ford, fantastic treatment option, standard of care. And then of course, the old Yugo, nothing's better than snapping this on a model, turning it upside down and watching it fall off. So that's one of the things I would recommend you do in your practice to help your patients understand. We can talk about implants that we did last time about all the benefits, maintaining bone, 75% of bone losses in the first year. We can talk about maintaining bone, quality of life, stability, retention, confidence, the ability to eat. All that stuff ties in here. So let's talk about the patients who can benefit from a bar. We talked briefly when we took a look at the Cadillac slide about patients who have a flat or atrophied ridge. And these are the patients who are going to come into your practice. This green cast on the left was a case I was involved in. The patient had 4 studs, and their complaint was, I don't have prosthesis. No, I'm sorry, let me rephrase that. They kept on coming into the practice every 2 weeks and saying, my attachments are loose. They could flip it up and down, even with 4 studs. Why? Because there was no lateral stability. There was no flange to engage to provide stability. So when you hear that complaint from a patient, my attachments are loose, repeatedly, most of the time it's going to be a lack of stability. And when we take a look at the patient satisfaction, this was a study from 2017. The number one thing patients want is stability. If we can provide one thing, let's provide stability. So, when a patient presents, you can take a look at, the patient on the left. We've got a nice tall ridge. The flanges of the denture will engage that and provide a ton of stability. We're fine with studs on this case. A couple balls, O-rings, locators. Patient is in great shape. Now, the patient on the right has probably been a dentureless for multiple years. We've got that flat pancake ridge. We're not going to have prosthesis stability here. This is a patient we can provide 2 studs for. Even if we go with something super strong, let's say the 8-pound purple locators, they're still going to be flicking the prosthesis up and down, side to side, and come into your practice and say, my attachments are loose. From a laboratory point of view, when I'm looking at the CAS, the blue area support, red is stability. I'm looking at the red, where's my prosthesis stability? So the patients can benefit from a bar. The first one is going to be that patient who does not have a ridge to provide stability. Second one is going to be that patient who doesn't have the dexterity or will not practice good hygiene. A lot of the times we'll see this with the fixed cases where we did a modified ridge lap, meaning we compressed tissue from the buccal to eliminate that phonetic hiss and that spittle and that black line. But what we require the patient to do is go in multiple times a day from the lingual, which is not easy, and try and clean it. And if the patient can't do that, worst case, they walk around all day being that patient who has bacteria and what they've eaten recently stuck under there, and they have terrible halitosis and bad breath. You take it a couple steps further, knowing that tissue is going to pull away from bacteria and they're going to start hissing and spittling. And if it continues that way, we'll start losing bone, and hopefully the implants don't pull out, but in this case, the implants did. So the second patient that a removable bar is ideal is going to be that patient that doesn't have the dexterity or hygiene to maintain something fixed. And so when we take a look at, fixed or removable, these are kind of the 3 primary indications. Inadequate lip support. We'll get into that a little bit, the dental facelift. We'll talk about the smile line, the prosthesis tissue junction. Third being good oral hygiene. Is it cleansable? And will the patient cleanse it? Because for a long time, I kept on thinking every patient's going to clean it. And like you, I've learned otherwise. Not every patient is going to do that. So, third patient who can benefit from a bar, poor bone quality. A lot of the times we'll see this in the maxilla where we're dealing with type 3 bone in the posterior. And just, as we know, bone quality is different in the maxilla than the mandible. We need 50% more titanium to bone contact to support the same load in the maxilla than the mandible, meaning to support 20 pounds of force in the maxilla, we need almost 9 square millimeters of titanium to bone contact. In the maxilla, only 6 square millimeters. So it's why when we're planning, let's say, an all-on-X case, on the lower arch, we could probably do an all-on-4 and be fine. Upper arch, we're going to plan to fail, maybe an all-on-5 or an all-on-6. More titanium to bone contact. So when we're talking about the different arches, maxilla versus mandible, just a couple studies here real quick. These are fixed cases, are all on X's. This was a study of thousands of cases, almost 10% bone loss in the maxilla, 2.7 in the mandibular arch. When we take a look at implant overdentures, now these are stud overdentures in the maxilla, we're up to 4 out of 5 implants failing, 20%. Whereas in the mandible, we're talking about 1 in 25%. So in general, in the maxilla, we want to protect our implants by splinting them together. So that's why we want to know the bone quality. You know, is it type 1 like oak wood? You know, it's dense, we can load it, we can cantilever off it. Type 2, you know, we're talking about like pine wood. Again, it's not as dense as oak, so it's going to integrate faster. But once again, we can cantilever and load off that. Then we get to type 3 and 4, you know, balsa wood and styrofoam. Type 4, we're not going to place into, but type 3, a lot of the times, once again, posterior maxilla, you're placing in type 3. The next patient who can benefit from a bar is going to be the patient with a high smile line. Because when we're doing our fixed cases, we need to place our implants at the smile line or above the smile line. So for this patient right here, from that black line down to the dentition, we would need to remove that much bone to have a successful restoration. And that's a question with the oral surgeon, yourself, and the patient. Do you want to remove that much bone? Every patient's going to vary. Every oral surgeon is going to vary. I would tend to be a little more conservative in general and perhaps provide something where a patient like this, if they're talking about fixed, they have the bone, they have the funds, they can have 4, 5, 6 implants. And we could provide something that's rigid, non-moving, so it feels like that fixed case, but they can remove it, cleanse it, service it outside the mouth, and be easier to work with. So it's not just the high smile line, it's also the medium smile line, because the medium smile line in the lower left, we also require bone reduction there. And 80% of the population having that higher medium smile line, this can be a challenge. And if we don't take that smile line into account, and this is where the digital pictures and videos come into play, and why, as a technician, I would ask my clinicians for this, is I want to see, you know, do we need to reduce bone? Because if we don't take that into account, we end up with a patient like this. This is lip line at rest, fixed case. This is a failure. This patient paid $60,000 for this. This is a failure. So what this patient was presented with, she was presented with a bar with attachments on it. Now, was she told she was getting a $60,000 denture? Absolutely not, because how many people are going to pay $60,000 for a denture? What she was told she was getting was a removable bridge, because by definition, that's what we're providing, a removable bridge. So next patient who can benefit from a bar is going to be that patient who wants to look younger, who wants that dental facelift. And these two pictures here are actual all-on-X patients where you can see kind of that sunken look and the vertical lines and how the face doesn't have fullness. This is, you're going to see this a lot with your older patients who have the all-on-X, who have had that bone atrophy twice as fast horizontal as vertical, because we don't have that lip support any longer. And, you know, as we mentioned earlier, one of the beauties of a removable prosthesis, we can replace both the bone and tissue that's been lost, as well as the dentition that's been lost. Whereas with fixed, that's very difficult to do. Yes, sometimes we can position the teeth to restore some lip contours, but is that the best, you know, for the patient? Are we putting the patient in a different situation with their bite? So again, removable, white and pink, fixed, just white. So I love this. I found this in one of the local magazines about 10, 15 years ago. It was for a local practice. And you can tell the patient on the left, this is kind of what it looks like when you've lost bone or you've lost those lip contours. Patient on the right, we've replaced it with pink and white with something removable, and you can see the difference. The patient on the white looks 15 years younger. It's the dental facelift. So again, with that removable bridge, we can do more to restore the patient's confidence, their aesthetics, as well as the function that we're desiring. So when we're talking about our bar design options, one of the first things that comes into place, obviously, how much space do we have, the position of implants, what's opposing, different things like that. There's two different types of designs we're going to be looking at. There's the rigid, which is fully above and supported, meaning we have good bone, we have multiple implants, and we're directing all the forces to our implants. Or we have something that's resilient, meaning either the implants are not in as good as bone, or we don't have them placed where we can be fully above and supported, meaning we're going to need to protect our implants when we go from above and supported to tissue supported. Most of the time, we're going to see it above and supported in the anterior, tissue supported, where the bite force is greater, and the posterior, and depending upon the biotype of the gingiva, there could be a little bit of movement or a ton of movement. So how do we protect our implants? We'll talk about that when we talk about resilient or tissue-supported prostheses. So first thing mentioned, we talked about space, and a lot of the times we're thinking vertical. You're trying to put a couple locators on a bar. You want 2 millimeters of open space between the implant and the start of the bar so the patient can clean underneath it. For a locator, you need 4 millimeters of bar thickness because we are going to tap and thread in our locators instead of casting them or laser welding them. And the reason I say that with a little bit of authority is because we're going to plan to fail. What happens in 10 years if you've cast a couple locators into the bar and they wear? Now, keeping in mind that the cast 2 locators don't have a titanium nitride coating, they're just stainless. What's going to happen when we cast 2 of those? Well, we're going to need to pull the actual bar, cut them off, and either drill and tap if we design the bar to accommodate that, or laser weld new attachments on. On the other hand, if we thread locators in there, it's as easy as going in there, threading out the worn ones, threading in new ones. We don't have to adapt anything. We don't need to cut out the housings. It's a simple procedure. So in general, if we're taking a look at one of our 3 types of bar retainers, this is attachments on a bar, we're looking at about 15 millimeters of vertical, which is a lot. But one of the things we'll want to take a look at, and this is where our 2 setup and our wax setup and try, and whether it's done analog means, or digital means, additive printing, subtractive milling. This is what we're going to be able to see is, can the patient accommodate that buccal lingual thickness of the flange? Because around that attachment housing, and knowing that attachment housing is 5.5 millimeters, do we have 2 millimeters of acrylic thickness on each side? Is the patient going to look, have their lip just jutting out? Or can they accommodate that? And if it's too big, we've got that's why there's hundreds of different options on the market when it comes to retainers. You can do something like a hater bar, and a hater bar only requires 10 millimeters of vertical, 7 millimeters buccal lingual. So, right off the bat, we're taking a look at space. And this is great to do when you're working in the digital realm. It's so much easier than when we used to work in the analog realm. So once again, when we're talking about our rigid or above and supported cases, this is 90% of functional capacity. This is the same as the all on X. If it's tissue supported, we're at 60%. And once again, if we're down to that conventional denture, we're at 10%. Our goal is to be at 60%, if not 90%. So the questions you want to ask when we're deciding resilient or rigid is basically, can we support all the teeth? Simple as that. And to do so, how far back can we cantilever? And to answer those questions, we're taking a look at, once again, the health and position of the implants, the bone, the patient health and hygiene, quality supported bone and tissue. And then one of the big ones is what's opposing, because this is probably the second question I ask when I'm working on a treatment plan is what's opposing. Because if I'm opposing a conventional denture or a partial denture, the bite forces are much weaker than if it is natural dentition or a full implant supported bridge. Now, if I'm supporting, let's say a zirconia, full roundhouse zirconia case with implants, I'm going to design it to have a little give, a little cushion, because I know that the patient doesn't have proprioception. there's no periodontal ligament like natural teeth, where when the patient starts loading it, that tooth can move 1 to 2 millimeters inside the bone. With implants, there's no movement. With zirconia, there's no give. So what am I going to design against it? Something that has a little bit of resilient function to protect the restoration. In fact, both the restorations. So resilient or rigid. And when we're taking a look at that, this goes from the treatment planning from day one. Where are we going to place our implants? Yeah, if we're going to place them in the canines, we come back to the bicuspids. We take a look at our AP spread. We can get 1 molar on here. Whereas if we place our implants in the laterals, we come back to the bicuspids, we can get 2 molars on this case. So this is where we work with our oral surgeons. They want to find the bone. We want to start with the end in mind. We want to start with what our definitive prosthesis is going to be and design the implant placement to support that instead of going, oh boy, Chris, what am I going to do here? We don't want to compromise because this is a major expenditure and a life-changing treatment for the patients. So when we're talking fully abutment supported and rigid, when we go into our digital realm, we can see where's the bar going to be. And the second digital picture on the right, this is why I love working in digital. This was a case I was involved in about 12 years ago. You can see that the patient didn't have enough space to have the prosthesis fully on top of the bar. You can look at the anterior, the bar was coming right through the setup. So this is where we take a look at different bar designs, different options, and different retainers. Keeping in mind that if we're going to go with a rigid design, we have multiple strong abutments, we're directing the force to the abutments, they're preserving bone and tissue, and it's going to be non-moving. And the patient in the upper right, you can see we're restoring those lip contours. They don't have the vertical lines. Huge benefit for the patient. So I mentioned earlier, this is the Porsche. This is what I provide my mom. It's not an overdenture, it's a removable bridge. Obviously, lip support, contours, we're protecting our implants by splinting them. This is a huge one, open palate. I mean, how many patients come in and want a palate? Nobody wants a palate of their prosthesis. Come on, I mean, patients want to enjoy life. They want to taste their food. They want to enjoy that, and with a good design of a removable bridge, we have a great palatal seal for speech, for function. It fits in what the patients want. They want something non-moving. And once again, you can service this outside the mouth and it's easy to clean for the patient. So that's why I said, to me, this is the best restoration on the market right now. Here's just a little schematic of kind of what this would look like. We have 6 well-placed implants in the maxilla. We have our 4 retainers, and you can see how when the patient functions, all that force is being directed directly to the implants. Now, if there's any opposing forces that are trying to disengage our prosthesis, for example, the patient's chewing, caramels or taffy or any of that stuff that people have been doing, especially the last month, you can see that's when the attachments function. They resist that dislodging force and maintain and keep the teeth in place. Now, the second option is going to be that tissue supported or resilient prosthesis. And a lot of the times this is where we don't have enough implants, or we have to place them all in the anterior. And we need to go from abutment supported to tissue supported. And we're going to treat this almost like we're talking about a partial denture here. If we're talking about a partial denture with attachments, we're coming off a bicuspid or a canine or even a lateral. Let's use the lateral, for example. How are we going to protect that lateral from those huge bite forces, that compression and that motion? Well, we're going to have 3 different ways we can do that. It's going to be via some resilient or tissue protective movement, abutment protective movement, straight vertical. It can be a sagittal movement, or it can be a hinge movement. So when we take a look at a case like this where we have a combination abutment and tissue supported, when the patient comes down, they bite, they swallow, they chew, and they're compressing tissue in the posterior, the anterior wants to lift off, kind of like, think of it like a teeter-totter. It kind of wants to move. And there's going to be some compression of tissue, and there's going to be a little bit of movement, but ideally the prosthesis does not dislodge. And as you can see from the retainer in the middle of the picture, as that anterior starts to lift up, that retainer is going to stop that lift off. That's the whole design of having that retainer there, is to stop the lift off. Now, what happens if we've got a super spongy biotype, or if the patient hasn't been presented to our practice in 3-4 years, and they continue to lose the supportive bone and tissue, knowing that we don't have any implants or natural teeth in that posterior to stimulate that bone and the blood flow in the nerves, and they're losing that supportive bone and tissue? Well, that's going to be even more movement and more torque or force on our abutments. And that's why relines are so important with the tissue supported prosthesis, because we want to manage those forces when we talk about how much force we're putting on the implant. It's torque equals force times distance. Now we know the force is greater, bite force is greater in the posterior. Depending upon where our implants are placed, let's assume they're in the anterior, that's a long distance. So that torque we're going to be putting down is going to be great on those implants. And what happens when we get force or torque on those implants is those implants want to bend. They want to move with that movement. And that's where you'll see some of the implants kind of blow out the side walls and stuff like that. It's not the implant's fault necessarily. What we can do is make sure those patients come back and check for a reline. And we'll talk about that more when we're talking about servicing requirements. So just a quick stat to kind of open some eyes. 1 of 4 new mandibular dentures require a reline in the first year. 2 out of 5 maxillary dentures in the first 3 years. So the other thing we're going to want to do when we talk about servicing is making sure we replace the attachments, because this is an example of a bar design that was extremely popular over the years, where we have a couple of hater clips up front, a couple of ERAs in the posterior coming, cantilevered off the bar. Nothing wrong with ERAs. They're a fine attachment, but what happens is they become the fulcrum and the axis of rotation. And if we don't reline that and maintain as much tissue support as possible, all of a sudden that's a huge motion on the attachment. And at best it dislodges, at worst it wears out extremely fast. So I kind of wish we were all sitting in the same room, because I would have said, hey, a couple hater clips up front, a couple ERAs in the back, what's going to wear out first? And I would have seen a couple hundred people say, the ERAs wear out. And I said, all right, everybody wins a prize, right? Like Oprah. But anyway, the fulcrum, protect that by relining and servicing the case. So let's take a couple minutes here. We'll talk about a general brief borrower workflow and the ideal setting. And of course, a lot of this is going to depend on, the NDX partner you're working with, what they're comfortable doing. This is just a general workflow. Right off the bat, we're creating our ideal denture setup. We're taking the existing, what the patient likes about it, or we're starting with a new denture. We're going through general steps, vertical, smile line, tooth position, making sure occlusion phonetics are good. We take that and we go into surgical planning. A lot of the time, as we're trying in that trial denture, you'll take a washer reline impression, and we'll take that, pour up our cast, we'll scan both of them, and we'll go into the digital surgical planning. And that's where the entire team, the oral surgeon, our restorative dentist, and our technician are involved, knowing that, hey, this patient would ideally like studs or bar or a fixed case, all on X. And we're going to place the implants in the ideal position to support that restoration. The surgical appointment and implants are placed, immediately provisionalizing that with our multi-units. And I'm going to pause there for a second, because I would strongly urge you on your bar cases to work with multi-units whenever possible. There's multiple reasons. Number one, we're moving the restorative platform at or above tissue as opposed to beneath tissue. We can correct any divergence between our implants. And it's obviously not going to be as traumatic for the patient as you're trying in the bar, taking the bar on and off. That's a traumatic experience. That hurts when the patient, you're at fixture level and you're going down and placing those long extensions to engage. So multi-units. Thirdly, we can have a more passive and easier to fabricate restoration. Next step, we're going to do our impression/record transfer. This can be analog or digital. Laboratory is going to send us back a verification jig. The whole purpose here is to verify our cast, because we do not want to go forward with fabricating a bar unless that cast is verified. There's two miserable phone calls I get. One is when the bar fits the cast but doesn't fit the mouth. Second is when you're doing a chairside pickup and locking an attachment. But going back to the verifying the master cast, please verify that master cast. And we'll take a couple minutes and go through multiple techniques for that, our try-in and prosthesis delivery. So our verification jig, believe it or not, I have to say this because I've seen plastic UCLAs used. Use a temp cylinder or an impression coping. Make sure they are non-engaging, because if they're engaging, there's going to be no way to get drawn pulled out. Even if you use an engaging and you rubber wheel off the engaging area, it's still not going to fit the same. Make sure it's a non-engaging component. It can be fabricated multiple ways. This is kind of an old school way, taking pattern resin, light curing it into place. And when it's seated, and you're seating this clinically, you want to make sure there's no gaps between the cylinders and the implants or abutments themselves. Take a radiograph, verify everything's fully seated, if that's the case. And also going back a step, when you're seating down your verification jig, you're kind of doing a clinical Sheffield test, a screw test, to make sure it's totally passive, and you're screwing them down and the other side isn't lifting off when you're placing them down. One technique. The other technique is going to be when the verification jig comes from the laboratory, each section is cut. And what you're going to do is you're going to loop these back together. A lot of the times you'll have an opening between the tissue and the bottom of the verification jig. You'll flow in your impression material and you'll pick this up in a new impression. And that lab will pour it up, and that will be the verified master cast that the bar will be fabricated over. One of the quick ways it can be done nowadays is in the digital realm as well. This is showing temp cylinders in the choice library at 3 different heights using the bar module. This is printed, cylinders are luted into place. It can be sent and you can try it in the mouth as one piece, or it can be sectioned. These should be numbered. It can be sectioned. And once again, you can see the open area between the bottom of your verification jig in the tissue. Get your impression material in there, capture them. Once you put them back together, pick it up in a new impression. The other part I want to talk briefly about this important record transfer is making sure you're working with a custom tray. So you can see here, we have our preliminary cast, our closed tray model has been, record has been fabricated. On the other hand, you can see right here where we fabricated it, you can see the retentive holes cut through for the impression material. So when we take this to the patient's mouth, inside of this is going to be our verification jig sectioned. We're going to lute the bar back together. We're going to flow our impression material in there underneath as well as all around it. Loosen up our screws and pull the impression. So again, multiple techniques for a verification jig. If you haven't done one before, I would ask your technician for a recommendation for what they have great success with. Again, there's tons of ways to do it. but absolutely make sure you do it. I wanted to throw in a picture of a multi-unit here, because when you're working with multi-units, sometimes there's the challenge. If you remove the multi-units and send them to the lab, how does the lab reposition them? My comment is don't remove the multi-units when they're in place, because this is really tricky to do. What you would basically do is make a seating jig for the multi-units in the mouth, meaning you would place your temp cylinders, you'd have your screws in there, you connect it with pattern resin. So when this came over to the laboratory, they could seat the multi-units back on the cast, use the jig to line everything up and go forward that way. So hopefully you'll never need to use this technique. If any of you out there have ever restored any of the older systems that were totally non-indexing, let's say an ankylose, it's the same thing as fabricating an ankylose seating jig. So keep your multi-units in place. We can skip the slide entirely. So after choosing the bar design, we have our wax setup and try-in. This can be wax, it can be printed, it can be milled. Old school, we make a putty matrix. Remove the teeth. We take a look at our putty matrix so we can see how much space we have. You can see the picture on the right with the teeth removed. We don't have much space at all. This is going to be very, very low profile. Whereas you take the picture here, this is everybody's dream. You have tons of space. Beautiful placement. We have 6 implants. We can provide the patient with almost anything they want with plenty of room. So this would be a traditional design. This is what your laboratory is looking at. They're finding room for teeth and acrylic and the retainers and the bar all in there. Whereas if you take this into the digital realm and you're working in the digital realm, we can set this up where just the teeth are there, or our proposed bar and the teeth are there. And we can move stuff around and we can do different designs. And it's so much easier than the old analog way. So it's, again, virtual matrix. This is a cross section of our desired tooth setup on top of the bar. You can see where the retainers are. And what's really beautiful about this is you can see where we need to reduce the size of the bar, where the bar is showing through. It just makes it really easy to see. And of course, there's an intaglio view of the prosthesis on the right. So then we talk about the different types of retainers. And the simple question of this, because it's going to be overwhelming with attachment, what kind of function do you want? That's the simple answer right there. What type of function do you want? Because with our overdenture bar attachments, there's 3 different types of retainers. There's a direct retainer, meaning part of the retainer is built into the bar, like a hater bar, a round bar, a dolder bar. The picture with the white cast. You know, it can be something that's incorporated on top of the bar, like threading in a locator or a ball or O-ring, or it could be offset. And a lot of the times when you're using an offset attachment is because you're fighting for vertical space. So you're going to position the retainer either distal of the bar or to the buccal or the lingual, depending upon space, so that you can pick up that restorative room. So we'll talk a little bit about each of these, why and when and where you'd use those. Hater bar or direct retainer is going to be the smallest bar option possible. 4 millimeters vertical, 3 millimeters buccal lingual. I love hater bars. I know they can be very confusing. And when it comes to hater bars, it gives us the choice of what type of movement we want. And it all depends on what restorative components we choose to use in the prosthesis. So for example, on the left side, if we take a look at that metal clip would give us both vertical and rotational movement. Now, if I was designing or choosing the restorative components for this cast right here in this bar, I would not choose that because we don't need that vertical and rotational. We don't need to protect those abutments. This is fully abutment supported. But if I had one straight bar section across the anterior, I would absolutely choose something like that metal clip because I want to protect that as we go from abutment supported to tissue supported. Now, for the bar case we're showing here, I would choose something like the plastic clips. They give a little bit of rotational and just super, super minor vertical. And the vertical is only the compressibility of the nylon themselves. But as we know, once we get to 2 and 3 bar sections, we lose the ability to rotate. Rotation is only on one straight bar section. So on a case like this with the plastic retainers, the entire prosthesis is supported by the bar and the implants. The beauty of these plastic clips is they make an audible snap. The patient knows it's engaged. It's comfortable to function over. They're not getting movement. This feels rigid. And they're easy to service. Patient says it feels loose. You pull out a clip, you pop in another one. Yeah, they're at Wendy's in 5 minutes. So just going back to what we talked about, if you want to have rotation with any bar section, it needs to be one straight segment. The minute you get a second or a third, like the picture on the right, there's no rotation. So we need to design our cases accordingly. Is it going to be rigid or resilient? So this is kind of a mind-blowing slide right here. I apologize ahead of time. I mentioned earlier how when I think about tissue-supported bar cases, I think about partial denture. So imagine this was, instead of our double abutments here, imagine this was a bar case. And class 1, no movement. These are like your dovetail attachment, stuff like that. We're never going to use that on a bar that needs to be tissue-supported. No movement, we're going to torque the abutments, it's going to break. A class 2 attachment is going to provide you vertical movement. Again, going tissue supported, this is dangerous. Now, class 3, if we have a hinge movement, this is great. This is going to function the way we want it to. It's going to protect our implants and protect our bar by transferring those bite forces to the supportive bone and tissue. Better yet, we choose something like class 4 that's both vertical and a hinge. We have the stress relief of the vertical, as well as that protective hinge movement. Taking it up a step even more, we get to a class 5 where we have vertical and rotational. Again, the beauty of this, when we get to a class 5 or class 6, is we don't need sagittal parallelism. So what I'm saying there is we're not always working in this, this linear arch where we're coming off of 2 bicuspids and everything's going straight down the long axis of the ridge. Sometimes we're coming off, let's say, a lateral. Now, if we put a hinge on that lateral, it can move this way. But how's it going to rotate this way? This wants to move down the long axis. We need to allow that sagittal movement. So these function together instead of fighting against each other. And this is where something that gives you rotation or a full omniplanar movement comes into play. So when I mentioned that there's tons of different attachments, and really what it comes down to is what type of movement do you want to have? Where are the abutments? Are they sagittally parallel? Are they not? What type of movement do you need? So the second style of bar attachment is going to be something to go right on top. And of course, a couple locators on top of a bar. These are threaded, easy to surface. Serve this. They give you full hinging movement, omniplanar movement. They're going to move 360 degrees to pivot. They're going to give you vertical. If we were placing these off the distal of a bar, these would be ideal to protect our implants. Now, the reason I wanted to show this here is I mentioned the second worst call I get, besides a bar doesn't fitting, is when you go to pick up an attachment in the mouth or you're impressing and you get impression material or acrylic underneath the bar and you lock it in. So use a cellulose-based material. You can use silicone, soft wax. I would recommend not using. It's going to run on you. Just something that is in place that'll protect your material from locking in underneath the bar. Now, I mentioned earlier about the third type of bar attachment being offset. You can see here on the left that the balls were placed, the 2 anterior balls were placed to the lingual, where the 2 posterior balls are placed to the buccal. They're offset. This is super low profile. But of course, the trade-off there is we need to make sure the patient had the buccolingual space to accommodate the placement of these. So there's two key offset attachments, one being the sagittal ball, the second being a plunger. And I love plungers because they give patients security. It's that peace of mind. When we're working with somebody, a lot of the time that is a musician, they'll want that to lock into place, because once those plungers, and the way it functions is there's a little hole in the bar drilled through, and the tip of the plunger engages through that bar, it's not moving. It's locked into place. So the beauty of this is, once again, it feels fixed. In the anterior, in this case, we have the yellow hater clip that makes an audible snap. So the patient's nose is engaged. They push the plungers in. This is not moving. They want to clean it at night, disengage the plungers, remove the prosthesis. Contraindication for this would be a patient who has limited dexterity and cannot engage and disengage the plungers. But this is an example of an offset case, limited vertical, awesome solution for the patient. Now, we mentioned servicing requirements. For our resilient or tissue supported cases, I would recommend every 12 months. We're going to check for a reline, have the patient show us how they're cleaning it, have it professionally cleaned, make any adjustments needed, and replace the attachments. In general, locators last every 18 months. O-rings last every 6 months. Hater clips can go anywhere from 12 months up to 12 years. I have seen hater clips for 18 years in the mouth. I don't know why you want to keep them for 18 years in the mouth without changing them, but the patient doesn't come back in. What can we do besides tell them to come back in, especially for relines? Now, our rigid bar patients, same protocol here, but we don't need to check for a reline because we're not being tissue supported. So once again, any adjustments, replacements, and have the patient show us how they're cleaning it. So once again, with these patients, I just wanted to highlight the blue one, that the average denture wearer sees a dentist approximately every 15 years after getting their denture. Can you imagine how much bone loss there is in 15 years? Can you imagine how much movement there is? These are probably the patients that say after year 2 or 3, oh, this doesn't fit anymore, and they put it in, put it in their nightstand, never wear it again. So as clinicians, as dental professionals, let's do the best we can to incentivize these patients to come back and service the prosthesis. We know that acrylic is porous. We know that bacteria goes through it. I mean, if any of you ever ground into a 20-year-old denture, it's the second worst smelling thing in the world. The worst is what I was dealing with at 5 a.m. this morning when I put my dog out and I hear a rustle and he got skunked. So that was a lot of fun. Yeah, me trying to get up 3 teenagers at 5 in the morning to help me clean the dog. Good luck with that. But no, it's terrible. So what we can do for these patients, make sure they understand, hey, come in every 12 months, and in 8 years and 10 years, we're going to give you a new prosthesis with white teeth and fresh acrylic, and you're not going to have bad breath, and you're going to look great again. And every 12 months, come on back in, incentivize your patients to do that. So I went over 3 minutes. I was trying to get a lot into an hour. So our course plan, identify the patients who can benefit from a bar. We talked about the patients who have a flat ridge, the attachments are loose, the patients who don't have the dexterity or hygiene, patients who have implants and poor bone, we're going to protect those. And the patients that had fixed and are used to it feeling fixed, but want to have something that they can remove and clean at night. The bar design options, we talked about tissue supported, fully abutment supported, as well as the different retainers and the function we want from those retainers to protect our tissue supported prosthesis. Workflow, that's a whole day right there, but brief overview there, and then some servicing requirements. This is my email right here. If you have any questions, please feel free to email me anytime. I heard from a whole bunch of folks after the last course, had some great discussions. You can reach me there. And at this point, I'm just going to say thank you. Appreciate it. It was a lot of fun, and hopefully look forward to hearing from a lot of you folks out there. It's fun having good conversations.